Welcome to Expanding Access, a podcast by Behavioral Health Tech, where we explore the cutting edge of mental health, substance use, and autism and IDD care. Each episode features insightful conversations with industry leaders who are driving real change through technology and innovation. Whether you're a provider, payer, or just passionate about expanding access to behavioral health care, you won't want to miss these stories. Let's dive in. Hello, everyone. I'm Solome Tibabu, your host of the Expanding Access podcast. And today I'm thrilled to have Michelle Turner with us. And we're going to talk about all sorts of critical topics surrounding child welfare, foster care. Just so excited to have you here. To get started, Michelle, tell us, who are you and a little bit about your background and your experience with child welfare.
Well, I am thrilled to be here with you. Any conversation with Solome is a good day. I'm Michelle Turner. I am the founder and CEO of Here Now Health. We are the first virtual healthcare company built for kids and families impacted by the foster care system. I've spent my whole career in healthcare, at the beginning, kind of at the local FQHC level, to running a global health telemedicine nonprofit. And before launching Here Now, I was with Hazel Health, the largest provider of school-based telemedicine. So I've kind of gotten my chops at each level of the healthcare system.
It's just incredible. I know so much of your story, and I can't wait for the world to hear as well. So this is great. And let me ask you, was there a particular client or story or turning point that really pulled you toward this topic of foster care?
Yeah, so it really honestly goes back to 2013. My husband and I became foster parents in the state of Georgia. And over about 5 years, we fostered over 40 children. And 4 of our 6 children are adopted out of foster care. So we had an experience with itty bitty babies up to 17, 18-year-olds that were about to age out of the foster care system during that time. And when we closed our home to fostering, I became a CASA volunteer, or court-appointed special advocate, and really requested that I be assigned to families that were at risk of family separation. So kids that were not yet in the foster care system yet, but their families were either on a preservation plan or under investigation, to really see if we could support getting resources in the home. And what I found in each of those instances was that even though I was working in the healthcare system every day, I was failing to get kids the mental health care they needed to thrive. And more than that, the results of that lack of care were really detrimental. Instead of kids getting therapy, they would sit on waiting lists, or they'd jump from home to home until they'd end up in crisis and in the emergency room, hospitalized, or in residential treatment centers because that was the only bed for them to sleep in, because the foster parents they had decided their needs were too great for them. And I started to ideate, what would this look like if we provided the right care for kids across the board within the child welfare system? And what would that look like as a virtual care company? I had seen that we had done this really well in other areas of healthcare, and no one was touching child welfare. And so as I was helping to scale Hazel Health, I started to also see that there's so many unique drivers to this population. We pay so much more for their care, and mostly crisis care. And government officials and health plans have a really high level of accountability for these kids, that it actually should be driving to better solutions instead of really terrible solutions, which is what kids are typically kind of stuck with.
And this led you to Here Now Health. So tell us more about that, and what's the ultimate goal with it?
So the ultimate goal for Here Now Health is to provide the very best care for kids and young adults impacted by child welfare. And when we say impacted by child welfare, how we look at it is any child that has Medicaid because of their foster status. So when kids come into the foster system, they are automatically covered by Medicaid because of that connection to foster care. So it's really unique within Medicaid in terms of kids are not covered by Medicaid because of the income of their parents or because of the employment or non-employment of a parent. It is really because of their own status. And so what we are looking to do is really create an environment where the lack of healthcare is never a reason that a family is separated, and it's never a reason that a child is in the foster system, but that we can actually use it as a preventative measure to stabilize families, to stabilize kids and young adults, and actually give them the best possible outcomes because of that access to healthcare. And so that's really our goal at Here Now, is to do that.
Amazing. And speaking of stability and permanency, I believe I heard that the odds of a child achieving permanency when they have just one case manager is something like 75%, but it drops down to just 17% when they have even just two. Can you say more about that?
That's exactly right. And just so kind of the audience understand, the case manager in the child welfare system is kind of like the glue that holds the system together. So every child in foster care has a case manager. They are oftentimes fresh out of undergrad, young, overworked, underpaid, and oftentimes female. So we're talking about a very heart-forward profession, but one that leads to a lot of burnout. And so case managers, unfortunately, turn over really frequently. And they are the ones that are supposed to be responsible for making sure kids have a stable placement, that they are in the right school, that they are getting their needs met. And when that person turns over or quits or leaves, and a child has to start with a new case manager, it's basically starting fresh with someone that knows nothing about you. And unfortunately, like you said, the more instability that a child in foster care has with their case manager, the less likely they are to have success, stability, and positive outcomes. And that really comes with any kind of change within foster care. The same statistic can be tied to a child's placement, the number of homes a child lives in. Every single time a child moves homes, their outcomes decline. And that includes the possibility for them to be reunited with their home of origin or typically their biological family. And so the more stability, the more we can keep a child in one place with the same caregivers, the same case managers, the better their outcomes are across the board.
So lots of pressure really to get it right, I can imagine. So with Here Now, who do you serve directly? Are you working with children, foster parents, agencies, providers, payers?
A little bit of everybody. So our number one goal is to provide longitudinal therapy to kids and young adults within child welfare, bringing specialized care that not only gets to them when they need it, but that can follow them wherever they go. So as you can imagine and probably have experienced, telling your story and then having to retell your story to new clinicians is really hard and traumatizing. So if you're a child in foster care, even if you get to start therapy or you start the mental health care that you need, if you move homes, most likely you're going to have to do that again. So our number one goal is to bring that care to the child and make sure that they can have that continuity even if they move. And one of the unique things about our clinical model is that we've built in caregiver support. And so the number one factor of stability for kids within the foster care system is actually the stress level of their caregiver. Caregivers, parents, foster parents, grandparents are making the decisions for the child. They decide this is too hard, this child needs to go. They decide, yes, I'll take a chance and allow that child to move into my home. And so if we are looking at supporting the system as a whole and we're looking at supporting the kids that are involved within that system, we have to include the caregivers in that. And so that is really kind of the cornerstone of the clinical model at Here Now Health, is not only providing care for the child, but providing that support to caregivers. And then from a broader standpoint, we are working with the Medicaid plans that cover children within foster care. And so we know that there's about 10x the medical spend for kids in foster care in comparison to their counterparts on Medicaid. And that is not good spend. That doesn't mean they're getting a lot of services other kids aren't getting. That means the majority of the care they're getting is crisis care. We're spending the very most for the very worst care for our most vulnerable population. And it is in emergency rooms, it's in hospitals, and it's in residential treatment centers and group homes. And so shifting that spend to early, lower cost, higher quality mental health therapy and supports is really what we're doing. And in doing that, we are trying to be the very best partner to managed health plans that are covering these foster lives by lowering their costs, but actually improving the outcomes of their members because we're getting the right care at the right time instead of just relying on crisis care.
Those are just some astounding numbers. Where do you think kids, foster parents, caseworkers are most often falling through the cracks?
So what we've seen and heard across the board is oftentimes it is due to transiency. So every time a child moves, they lose so much of themselves. They lose their information. They lose their providers. They lose their school and their teachers. And so when we talk about kids falling through the cracks, the biggest cracks happen every time a child moves. And so again, that's one of the most, I think, powerful aspects of virtual care is that it can move with the child. It can follow them. It can go wherever they go. And again, the biggest goal is actually to keep kids stable. But when they do move, planned or unplanned, that goal is that the care will actually go with them. So that is what we are, building an ecosystem that essentially is built around the child and the realities of their life, rather than trying to make them fit into kind of the traditional healthcare system.
Such a complex space, I can imagine. What have you found are some of the more common misconceptions that you run into as it relates to foster care and their mental health needs?
So I think one of the biggest misconceptions is that foster kids are kind of all our kids involved in this foster system are all similar in terms of their needs. They're very diverse. There are consistencies and similarities, but there are kids within the foster system who struggle with depression and anxiety, and some struggle with suicidality, and some struggle with ODD. There is a diversity in terms of the needs, in terms of the diagnoses, and in terms of the type of care that they need or they lack. And so when we're looking at a clinical model that is meant to serve the child welfare system as a whole, we have to have a lot of clinical nuance to meet those diversity in needs. And so we are building for the consistencies that we can. And much of that is, again, around that caregiver support, involvement of case managers and other stakeholders within a child's life, but then also really building for the diversity of the needs that we see exist across the population. And so that is one of the biggest misconceptions around kind of the needs, is that there is a diversity in needs just like with any other population.
So important. Could you think back in the last few years, were you reminded of any moments that were like, wow, this is really why I do?
Yeah. So when we first launched clinical care actually this summer at Here Now Health, and we launched here in the state of Virginia, which is our home state. And one of our very first aged out youth who came to us for therapy, after his first session, his kind of feedback to us was he had been forced in therapy most of his life as a foster child and never chose to engage. And after just one session with Here Now, he said it was the first time that he felt like therapy had been built for him. And that is literally the whole reason why we exist. And it gives me chills just even, talking about that now, is that, in that first session, that young man felt like we existed because of young adults like him. And so I would say that gave a lot of confirmation that we are building something very different, very unique and specialized. And there's a lot of power in that. And there's a lot of impact in that. And so I would say that's one of my favorite stories to date about our existence and the reason why we are here.
That's just incredible. It reminds me, I hear quite a few clinicians who say, I'm trauma informed, but what does that actually look like in practice? Can you talk a little bit about your approach to trauma informed care?
Yeah, I think one of the problems that when we talk about trauma informed is that a lot of people think that it just is related to the clinical care that's provided. And we're looking at it much broader. How can we provide a trauma informed experience? And that starts with our intake form. Something that I learned as we were building out Here Now is there's a lot of trauma in being asked for information. When you've been involved in a state government system like child welfare, you lose a lot of autonomy. People think they have full access or should have full access to all of your information, and they can do with it kind of what they please. And so in our intake form, when we ask for information, we tell you what we're going to do with it, or we ask permission to, receive that information and then, for example, bill Medicaid. And so trauma-informed to us is not just related to our clinical care, but it's related to our experience across the board. When we send emails with reminders about appointments, we have worked really hard to make the language trauma-informed. So it doesn't feel judgmental if you need to miss an appointment, but it also encourages you showing up and letting us know if there's a reason why you can't show up so that we can help you reschedule. And then, of course, it is also integrated in all of our clinical care. But I think when we're talking about being trauma-informed, we need to think beyond just the clinical care to ensure that every aspect of our clinical model and our experience that our clients and our patients have with us is truly trauma-informed and makes it so that our youth and young adults want to engage with us, that they feel safe, they feel understood and seen, and it makes them want to come back.
Really, really great examples. So I know there are some challenges, plenty of challenges in this space, but the fact that policies are varying by state, I'm guessing that causes some friction.
Yeah. And we're taking, two of the most complex government systems, healthcare, Medicaid, and child welfare, and trying to kind of force them to work together and work really well together. I heard from one Medicaid leader at a conference that if you know one state's Medicaid, you know one state's Medicaid. And I think that could also translate over to child welfare. If you know one state's child welfare system, you know one state's child welfare system. And it doesn't make it easy, but at the same time, I would argue that kids and families involved in child welfare, we owe the greatest to in terms of high quality healthcare, in terms of solving this problem. And we believe it is a very solvable problem. And so while there is basically every single state operates a little differently, it also, I would say, in every single state, if you talk to a government leader, if you talk to a Medicaid or health plan leader and you ask them, what pediatric population are you the most concerned about? Almost every single one will tell you kids that are involved in the foster care system. And a big reason for that is we know that there is a direct child welfare to prison pipeline. There are, if we look at adult outcomes and we want to improve the outcomes of the adults that are the ones that are really our future and our, if we want to have the biggest impact in the next 10, 20, 30 years, the best way we can do that is by taking care of our kids that are the most vulnerable. And almost anybody will say that those are the kids that are within the child welfare system. And so I think it also, just like anything else, where we have the greatest downfalls, we also have the greatest opportunities.
Couldn't have said it better. If you could just take a magic wand and pass one piece of policy, what would that change look like?
I would say that when it comes to Medicaid coverage within this population, every single state covers kids that are within child welfare. But then there's a lot of differences in terms of the kids that are kind of adjacent to child welfare. And that includes kids that are, again, kind of at risk for foster care, kids that are on preservation plans, families that are on safety plans. And if I was to have one across the board policy change, it would be that any child that is at risk for foster care would automatically be put on Medicaid. And the reason for that is that it offers such an incredible opportunity for prevention. It is my belief, and it is the belief of many, that children should never be coming into the foster care system because of lack of healthcare access. It's not just an ethical issue. It is the very most expensive way to get kids healthcare. And so if we have identified a family or a child of being at risk of foster care, the smartest thing from an economic but also a healthcare perspective is to make sure their healthcare needs are met. And so the easiest and honestly the cheapest way to do that for a state is to give that child Medicaid access. And so across the board, if I was to say there's one thing that we could snap our fingers and have an incredible impact, it would be that any child that is at risk of foster care be automatically placed on Medicaid to ensure their healthcare needs are being met and to make sure that that is not a reason that they do potentially enter the foster system.
And how about for payers? Let's say if you're connecting with a Medicaid director or an MCO, CEO, what advice would you offer them to improve access and care for foster kids?
So I think you have to really look at this population uniquely. There's some really unique needs, and because of that, you have to consider solutions that are really tailored towards meeting those unique needs. I spoke with a health plan leader very early on in my journey, and she said, the thing that we don't want is our kids in foster care to just be an add-on. And what she was talking about was, some behavioral health companies had essentially come and said, hey, we can serve those kids too. We're already serving pediatrics. Give us your foster kids too, or your kids on your foster plan, and we'll serve them as well, without any real strategy for uniquely meeting their needs. And that's what she said they really didn't want. And again, that's really our whole reason for existence, is we are building to meet those unique needs. And so I would say if you are a health plan that wants to do right by kids and families within the child welfare system, you have to differentiate your approach and really think about meeting these needs uniquely and partnering with organizations like Here Now to do that. I've seen some really cool things. In Kentucky, for example, kids who are on Medicaid because of their foster status automatically get a cell phone at 14, or at least they're eligible for a cell phone at 14. That's not something that every child on Medicaid has access to, but for a child in the foster system that may not have access to a cell phone, otherwise, that need is being met by their Medicaid plan. And so I've seen other really unique kind of resources provided through a Medicaid plan when it is thinking about this population and their unique needs and not just lumping them together with the rest of the pediatric Medicaid population.
Yes, just great advice today. And Michelle, if I could close out with one more question, where did the name Here Now come from?
Yeah. So Here Now Health came from a story kind of right in our home. We've been fostering for about a year. And my husband and I have two biological children. They were age 5 and 2 when we started fostering. And our son was taking a nap. He was about 3 at the time. Our case manager called and asked if we could take placement of 2 little girls. And I told her, yeah, we could, but I had a sleeping toddler. And if there's one kind of parenting strategy I go by, it's that you never wake a sleeping child. So I asked her if she could drop those 2 girls off, which she did. I got them playing in our playroom. And just a little bit later, our son comes down the stairs and he looks at these girls that he had never met before playing with his toys. And he looked at me and he goes, Mom, do they live here now? And that was just his, he didn't ask who they were. He didn't ask what their names were or why they were playing with his toys. He just asked if they lived here now. And it made me think that, our toddler had come with this level of openness and acceptance with these 2 brand new girls in our home. And over and over again, I was trying to get pediatricians and therapists and even teachers to show that same level of acceptance to the kids that were entering our home. And so as we were building Here Now, and we didn't have a name yet, and we were trying to think of what is the one thing we can do when a family or a child first comes to us. We can't solve all their problems. We very well may be meeting them on the worst day of their life. The most important thing we can do is we can be here now for them, whatever that looks like in that moment. And so that's where the name genuinely came from. And it's one of my favorite stories to tell because it hits the reason why we are here and do what we do.
That is just so beautiful. Thank you so much for sharing. And I hope our audience will reach out and learn more. HereNow.health. Please inquire and support this great work because obviously there's huge need and just amazing, Michelle, you and your team, what you're doing. And thank you for joining us on the podcast.
Thank you. So great to be here.
Thanks for tuning in to Expanding Access. We hope you're feeling inspired by today's discussion. If you've enjoyed the episode, subscribe and share it with your network. For more content and opportunities to get involved in transforming care, visit behavioralhealthtech.com. Until next time, Let's keep pushing boundaries and expanding access together.